Thank you all. And we now have our next speaker is going to talk to us about yet another very difficult to manage opportunistic infection that we see in people with HIV, less frequently in the US than maybe outside of the US, but certainly in people without HIV as well. So Dr. David Boulware is the McKnight Distinguished Professor of Infectious Disease and International Medicine at the University of Minnesota. He's an infectious disease physician scientist who has based most of his research career on the clinical and translational and pathogenesis research related to cryptococcal meningitis in resource-limited areas, and probably one of our world's experts on this disease in that setting. He has been also working in the area of TB diagnostics and TB meningitis to improve the treatment of that opportunistic infection as well. He currently leads a multidisciplinary international research team with collaborations with partners in Uganda, South Africa, Ethiopia, Brazil, Botswana, the Netherlands, and the United Kingdom. He's going to talk to us today about cryptococcal meningitis, the state of the art for diagnosis, treatment, and prevention. Dr. Boulware.
Thank you very much for the introduction. We'll get started here. So my disclosures are here. Cryptococcus is not a big commercial venture, but I do have some collaborations. The objectives really today about talking about diagnostics, treatment, and prevention. So fairly straightforward. And we'll work through these topics. And so let's start with sort of the background. I assume most of you guys already know about Cryptococcus, but it's a yeast that's in the environment. Everyone has been exposed, so congratulations, everyone that's in the audience. You probably have yeast that are sort of dormant, sitting in your lungs. And if you become immunocompromised, that can disseminate, and disseminates really throughout the body. And while we think about Cryptococcus as a meningitis, ultimately it's a disseminated infection, and it's really a meningoencephalitis. And when on autopsy, you can find it throughout the body. And so it's not just a pure meningitis, but for simplicity, we do call it cryptomeningitis. And so overall, this is causes a substantial burden of age-related deaths globally. And so the estimate in 2020 was 19%. And so even though it's certainly less common than TB, it's highly deadly when people do develop it. And so how common is it? When you look at meningitis cases in sub-Saharan Africa, in particular, Cryptococcus is the most common etiology across a variety of countries. And so where I work primarily in Uganda, it's more common than all other causes of meningitis combined of those who reach the hospital. And this really hasn't changed over the last 20 years. And so the total number of cases have decreased a little bit in South Africa per national data, has decreased a little bit in Uganda, but really quite minimally. And so even with the rollout of antiretroviral therapy, it's something that we still see quite a bit of. And so the symptoms of meningitis, sure, you can have sort of full-blown meningitis, and this is sort of very advanced late-stage disease, but it can be very subtle. And so people can just present initially with a mild headache or with minimal symptoms at all. And so this is something that is a little bit more difficult to decipher just by symptoms alone. So how do you actually diagnose it? So there's a variety of ways that have been used over the years. And so we'll start with our sort of first question here and so the test is the question is worded deliberately. So which test has the best diagnostic performance to exclude cryptococcal disease? So is it Indy Inc. culture? Is it Craig by latex agglutination? Is it the Craig or cryptococcal antigen by lateral flow assay on CSF? Is it the serum cryptococcal lateral flow assay, or is it PCR on CSF? Okay, so all right, so some people did the pre-test stuff, which is good, and paid attention. And so when talking about cryptococcal disease or cryptococcal infection throughout the body, you can certainly have this as just positive in the blood alone, and the CSF can be initially negative. And so we'll go through a little bit on the diagnostics here. All right, so when you look at indie ink, so old school, you need a microscope that works. That's about it, and a technician that's trained to look at it. That's about 60 to 85% sensitivity. And so for high grade disease with people showing up very late, this is fine. This will work. But for people with early disease with lower burdens of infection, particularly below 5,000 sort of colony-forming units per milliliter of CSF, the sensitivity drops off quite a bit. And so therefore, those that have the least amount of infection, the easiest to treat, you're going to miss with just microscopy alone. So there's CSF culture. So CSF culture is great. If you have a high burden of infection, it may grow in 3 or 4 days. Usually most infections will grow within 7 days. And so that's great in hindsight. You can say, oh, a week ago, they had a positive culture when it was drawn, but it's not really very useful for decision-making in the moment. So there's cryptococcal antigen tests, and so there's a couple different types. So for those that have been around for a while, you're likely familiar with the latex agglutination. This works fairly well. It's fairly sensitive, fairly specific. There can be some weird false positive reactions that one can get with latex agglutination. It's actually relatively expensive when you implement it. And so even though the assay might be $5 a test to buy, you got to ship it cold chain, you got to store it cold chain. And so if you're in a low and middle income country, that cost actually becomes quite high. If you're in a high income country, it's fairly labor intensive for the lab staff to sort of mix it up. And so it's costly that way. And so it's a relatively expensive test, even though the assay itself is mainly only $5. There are different manufacturers, and these have different performances, notably with Cryptococcus gaddii, where some manufacturers sort of miss that serotype. So what's new? It's not really new. About 12 years ago, the FDA approved the lateral flow assay, and so this costs basically $2 in low and middle income countries, $5 in the U.S. And this is a really great assay. It's simple. There's no lab infrastructure needed, and it can be done really anywhere. And so this is sort of just an immunochromographic point of care lateral flow assay, and so people are fairly familiar with these nowadays. It's very simple. 1 drop of diluent, 1 drop of a specimen, which could be blood, could be serum, plasma, CSF. You insert the strip, and within 5 to 10 minutes, you read it, and it's boom. It's very great. And so when you look at the diagnostic performance, we looked at a few years ago about this across a variety of assays. The lateral flow assay, the LFA, had great sensitivity, great specificity. When you look at culture is really volume dependent. And so the larger the volume of CSF, the better the culture burden is, similar to anything in microbiology. Indie ink was only 86% sensitive in this cohort. And the most common diagnosis among people with a negative indie ink was still cryptococcal meningitis. And so it's not a very good test because the negative predictive value was only 80%. And so not ideal. And then the different manufacturers of the latex agglutination and notably different specificity with those assays. There's also PCR that was approved not quite a decade ago, so I think it was 2016, 2017 when it was approved. And the film array is used by a lot of community hospitals, and so it's fairly reasonable for bacterial meningitis. Some of the viral meningitis it can miss. And for crypto, it's good for high-grade infections, but it can miss low-grade infections. And so I'm happy that's on the panel because it'll be kind of an accidental positive when it's found. But it's certainly, just because you've got a positive PCR does not exclude Cryptococcus. And so we've looked at this in particular in the context of the colony-forming unit. So we can do a quantitative culture and figure out what the culture burden is, the number of yeast per milliliter of CSF. And so when you've got greater than 100,000 yeast, it's pretty good. We only had 1 false negative in the bunch. But as you get down low, particularly less than 100 CFUs per milliliter, it just misses things. And so once again, people with just cryptococcal antigen positivity, with a sterile culture or a low culture burden with just 100 yeast per milliliter, so low burden of infection, very easy to treat, but would be negative by PCR most of the time. And so the line there up top reflects sort of the cumulative sensitivity, which is related to the fungal burden. And so for high-grade infections, yes, it will pick it up, but early infections, or just those that are easier to treat, it will miss. And so not an ideal test by any means, but the one thing it is good for, particularly at time of second infection. So if you have a relapse and you're sort of thinking, is this iris versus is this a paradoxical iris event versus is this culture positive relapse? PCR can be quite good because for iris, where typically the culture is sterile, the PCR will be negative. Versus if you've got a relapse with a positive yeast, then on culture, oftentimes the PCR is positive. And so while it's not a great test for a first episode, it can be a very good test for second episodes of Cryptococcus when people have sort of suspected relapse versus paradoxical iris. And so because nothing else really, the Craig will still be positive, culture will take a week. And so this can be quite useful diagnostically for clinicians to kind of guide, oh, the PCR is negative, I think, and it fits with a paradoxical iris event and going down that way versus the PCR is still positive, then thinking about culture positive relapse. And so that is really one of the unique roles where PCR can be quite useful. The same thing could be said at the end of therapy if you want to know, like, oh, are they negative on day 14 of your induction therapy? If the PCR is negative, likely it's going to be sterile. And so that can be slightly better than just waiting on the culture to come back a week later. So we'll throw out a case vignette here to think about things. So we have a 32-year-old female with a low C4 count of 25, presents with a 2-week history of progressive headache. Lumbar puncture has a few white cells. Protein just a little bit abnormal. Glucose is normal. The cryptococcal antigen test is negative. Microscopy for gram stain, India ink, and AFB are all negative. What would you do next? And so the lab says, oh, we've got 1 milliliter of blood, 1 milliliter of urine, and 1 milliliter of CSF. What would you want to test? You know, what would be your highest, perhaps highest diagnostic test here? Would you want to do CSF India ink? Would you want to wait for the CSF fungal and TB cultures? You can kind of go on vacation for a month and come back for the TB cultures. Would you want a serum cryptococcal antigen, urine cryptococcal antigen, or a gene expert for sort of expert MTB ultra assay? Okay, so serum test. And so we'll kind of walk through this a little bit. And so to kind of explain a little bit, so we talked about India ink is less sensitive than the lateral flow assay. You know, cultures will take a week and are not very diagnostically useful, and cultures are less sensitive than the cryptococcal antigen test. The urine can't be run for the cryptococcal antigen. You think like, oh, we run antigens for histoplasmosis and other fungal infections, but the cryptococcal antigen lateral flow assay just doesn't work very well in urine, and there's been reported false positives. The gene expert, you really do need more than 1 milliliter of CSF for that to be a useful test, and it's really sort of volume dependent. And so if you want to exclude sort of cryptococcal infection overall, looking at the blood can be quite useful. And so in particular, when we looked at people that came in, this is in Uganda, with suspected meningitis, about almost 75% of them were positive by finger stick. They matched, it was 100% concordant in sort of serum and plasma testing. And then there was sort of this 7% gap of people who were positive in plasma, but negative in CSF. And so this sort of symptomatic cryptococcal antigenemia group, where they, on the progression from sort of no symptoms to symptoms of meningitis, there's this sort of gray zone of this sort of early meningitis where people are positive in blood but negative in CSF. And so sometimes you can see cells and elevated proteins. Sometimes the CSF is very bland, but they've got a headache and they got some symptoms of meningitis sometimes. And so this group, if you just look at the CSF only, you can just be like, oh, all the tests were negative. We did PCR, we did next-gen sequencing, we did all sorts of stuff, and it was negative. And so generally for immunocompromised patients who come in with a CNS syndrome, obviously you do the LP and you look in the CSF for crypto. I'll generally always order a blood test. And so looking in plasma or serum for the cryptococcal antigen as well, just to pick up this group, because this is, you know, it could be a misdiagnosis where, yeah, a week or two later, these people will eventually progress and be positive in the CSF. But initially they'll be negative. And so the symptomatic antigenemia group in Uganda is the sort of the third most common cause of meningitis. So if you look at the people who are, you know, CSF positive, that's sort of most common. TB meningitis is the second most, and then this is the third most common cause of meningitis, and it's actually more common than bacterial meningitis. And so it's one of those things to look at, because if you're not looking for it, you'll miss it. And you would think, oh, this probably they've got TB meningitis, and we just can't diagnose the TB. And so you just don't want to miss the symptomatic sort of cryptococcal antigemia group, because they're easy to treat. So what are the principles? How do you actually treat people? What are the principles of antifungal therapy for this? And this has changed a little bit over the last decade and a half. And so question number 3 here. So in the first week of cryptococcal meningitis therapy, what has the largest impact on improving survival among people who are getting amphotericin-based therapy? So is it adjunctive flucytosine? Is it adjunctive fluconazole? Is it controlling intracranial pressure? Or is it giving liposomal amphotericin B versus deoxycholate? What do people think today? Okay, we got a mixture. Okay, this wasn't a pretest. Okay, so actually people did pretty well. So the biggest thing was actually, I agree with the 40%, the intracranial pressure management. And so when you do, so the current IDSA recommendations from 2010 are to do a therapeutic, to do an initial diagnostic LP, measure the pressure, and if the pressure is more than 250, to repeat this on a daily basis. And so we looked at this a few years ago and quantified what that impact was. And so let me show you the data here. So this is outdated. We're going to skip through this, but I'm going to show you the data, but we're going to get to this first. So if you look at just amphotericin therapy first, so amphotericin, deoxycholate, old school people know it causes nephrotoxicity, causes hypokalemia, hypomagnesemia. On average, you get about a 2-gram drop in hemoglobin over the first week. The liposomal formulation has fewer side effects, but it has the same outcomes. So there's not any better outcomes than deoxycholate. 1 week of amphotericin is as good as 2 weeks, and it's less toxic. And so this is the active trial. And so people are it was a factorial design trial. People are randomized to 1 week versus 2 weeks. And you can see the curves overlap. And so giving 14 days of amphotericin is not a magic duration. So if people get 7 days, that's pretty good. And giving them more is, particularly in the second week, is going to give more toxicity, but it's not going to really improve their outcome. And so particularly if you're giving therapy and you're running into toxicity in the second week, I've been called about cases where we got to get that 14th dose, and so they're putting the person on dialysis, and so they're really harming the patient by giving a lot more drug. And so if you give at least a week of drug, if you're doing daily dosing, that's certainly adequate. And so giving beyond in the second week can be a bonus, but is not really going to improve your survival in people with advanced HIV. The second thing is adjunctive flucytosine is superior to fluconazole. And so in this trial, the mortality was reduced from 45% with adjunctive fluconazole to 31% with flucytosine. And so now in multiple studies, Jeremy Day's study and going back to the Vanderhorst trial, amphotericin plus flucytosine, continues to have sort of a benefit in all of these trials. And this is a large statistical benefit here as well. And so the 2018 WHO sort of preferred regimen was giving amphotericin with flucytosine for 1 week, followed by high-dose fluconazole at 1,200 milligrams, then followed by 800 milligrams, and then through 10 weeks, and then secondary prophylaxis thereafter. So what's new? So things have changed a little bit. And so with the Ambition trial, which came out in 2022, was looking at single dose of liposomal ampho at 10 milligrams per kilo, given with 5-FC and fluconazole versus that WHO standard care of 1 week of deoxycholate with 5-FC followed by fluconazole. And so in this trial, it was designed as a non-inferiority trial, and there was no statistical difference in outcome. And so as you can see, the lines are there. The single-dose liposomal ampho regimen was a little bit better, but these are not statistically different in the unadjusted analysis. In the adjusted analysis, it was better. And so the trend was certainly that the liposomal ampho people had less toxicity. And so that was probably what helped sort of drive the mortality, the trend towards slightly better mortality, but it was non-inferior, it was not statistically different. And so when you look at the actual antifungal clearance, because when you give amphotericin, it stays around for a long time. And so you can measure this weeks and months later in spinal fluid and in tissue. And so this is sort of each individual patient is a line here, and doing serial quantitative cultures, you can estimate the rate of CSF yeast clearance, termed early fungicidal activity. And so the rate of this yeast clearance over these is the same between the two groups. And so the antifungal effect was the same. And so that's reassuring. Also, the survival was the same. So even though you're only giving one dose and you're like, it's day 2, it's day 3, like, what do I do? Like, that amphotericin is still present, and still you're gonna have killing of the yeast present. And so, but what is also important is controlling pressure. And so, as I mentioned, sort of in the question, like, this is one of the highlights of this. And so yeast do obstruct the outflow of CSF. And so it's not really caused by edema, but just that obstruction of the CSF outflow. And so typically more than 200 millimeters of water is considered high, and the median in the Van der Horst and other earlier trials was around 250. And so that's sort of why 250 is this magic threshold. And the solution to really control this is by doing therapeutic lumbar punctures. And so in a sub-study that we did a few years ago, we had a protocol where we did schedule LPs, sort of a day 1 and day 7 or 8, and then day 14. And about a little over half had high pressure. And in that first week, we offered sort of therapeutic LPs, but the IRB made us have people able to decline the LPs. And so they didn't want them. People didn't really like LPs. There was sort of some stigma against it. And so about 30% received at least one therapeutic LP in that. And overall, they had a 69% relative reduction in 10-day mortality, regardless of their baseline pressure. And so of those who had a normal baseline pressure, who would not be sort of recommended to get a follow-up LP, if they did get a follow-up LP, there was 0% mortality versus 16% mortality over time. And some of those that did have high ICP, who should have also gotten an LP, also had an improvement. And so there was an improvement in survival regardless of your baseline pressure. And so what we recommend is to do a therapeutic lumbar puncture, basically do scheduled lumbar punctures on day 1, day 3, day 7, and then at hospital discharge near day 14. And most of these therapeutic LPs occurred in the first couple of days after diagnosis. And so more therapeutic LPs generally better survival. And so we've repeated this, looking at what's the longer term outcome after 30 days. And so this is a separate cohort, different time period. And so of the people who survived 7 days, those who got 0 therapeutic LPs in that first 1 week, you can see kind of there they had the worst survival. And versus if you got 1 or 2 therapeutic LPs in that first week, they had better survival. And so regardless of your baseline pressure, we would recommend to do a therapeutic LP. And usually I would say 48 hours later. And so sure, if it's a weekend or Sunday, you can move it a day or 2. But we would recommend sort of 1, 3, 7, and 14 as far as LPs go. And so things that don't work, so mannitol, acetazolamide, or steroids really don't work to reduce ICP. The exception may be in Cryptococcus gattii and HIV negative persons, where there can be more inflammation, and so steroids have been used in gattii. But in persons living with HIV, these don't really work. And so kind of the key points of measuring pressures, which sometimes in just general practice is a problem, where, yeah, they had an LP, well, what was the pressure? Oh, we didn't measure it. And so if you didn't measure it, if it was not measured in the emergency room or wherever, I would repeat the LP within 24 hours to measure the actual pressure, because controlling pressure is really key on that early mortality reduction. So there are actual problems with this. There's difficulties in implementation. You can improvise with IV tubing and a measuring stick. Oftentimes you don't know the diagnosis until the LP is complete, and so people don't measure the pressure because they didn't know they have Cryptococcus. And so some of the things you can do is you can do a finger stick, or you can do a blood test before you do the LP. And so if you already know they're Craig positive in blood, then you basically know they have Cryptococcus, and you know you need to measure the pressure and reduce the pressure. If you're in a low and middle income country where you don't have manometers, the median volume we remove on our first LP is about 25 milliliters. And so feel very comfortable to remove 20 to 30 milliliters of spinal fluid. If you're only removing 2 or 3 milliliters just for your diagnosis, for Cryptococcus, that's not going to be adequate. So if you know they have Cryptococcus, you do need to remove a fair amount of fluid generally to normalize the pressure. And if you don't know you can always, if you don't know the pressure from the baseline diagnostic, repeat it the next day. So sort of summarize of how to optimize care, using a rapid diagnosis, using shorter, less toxic regimens. And so the single dose liposome LAMPO, I find is very easy. There's no difference in overall outcome, but there is less toxicity, and it's just much easier to give. It's much simpler. If you're experienced and you've used amphotericin for 40 years, sure, you know how to measure and sort of monitor outcomes and side effects and toxicities and manage all that. But the single dose, you don't have to do that. So it's just much easier. And then supportive care, controlling intracranial pressure, IV fluids, and electrolyte supplementation for those with getting amphotericin, and looking out for other OIs. And so all the things that people are talking about today, just because you've got one OI doesn't mean you can't have another. And then we defer HIV therapy for 4 weeks, at least 4 weeks after diagnosis, making sure people are walking, talking, and doing or at least clinically stable. So what about prevention? So preventing disease, it's always easier to prevent disease than treating it once it's there. And so we showed this sort of diagram before. And so this sort of step of early dissemination really occurs over 1 to 3 months. And so this occurs over quite a bit of time. And so you can block this step and prevent progression. And so this cryptococcal antigen can be detected weeks before the onset of meningitis. And so we do in Uganda and as well in South Africa and a number of other places, sort of a reflex cryptococcal antigen screening when people have a CD4 count. And so they have a CD4 count less than 200, and you can use the leftover plasma specimen to run cryptococcal antigen to detect the antigen. And even if they're asymptomatic, this is going to progress if they're untreated. And so when you look overall, it's about 5% of people with a CD4 count less than 200 will have a cryptococcal antigen positive in their blood. So 1 out of 20 people coming in, walking into the clinic in the outpatient setting. If you start doing testing in the hospital or other places with sick people with symptomatic, it's going to be much higher prevalence. But if you look at all comers, and so these bounce around a little bit. In the US, was a little bit lower. It was 2.6% in one study. But there's a confidence interval for all of these. And so I kind of think about it's 1 in 20 on average. Some places maybe a little bit higher than others. So what happens if you just give them HIV therapy? Oftentimes people will unmask their disease and they'll die basically, or they'll be like, oh, this looks like toxoplasmosis. It's a ring-enhancing lesion, but actually it's a cryptococcoma. And so this is one outcome. And so what happens if you treat for it preemptively? So in a study out of Tanzania and Zambia, that basically they reduced mortality by about 1/3, from 18% to 13% in a cohort with CD4 count less than 200 by giving Craig screening along with community support with ART counseling. And so, fairly significant impact here. And so the current WHO as well as US recommendations are to strongly recommend screening for people who have a CD4 count less than 100 and consider it above or less than 200. If you're Craig positive and asymptomatic, then to give preemptive therapy with fluconazole for 800 milligrams for 2 weeks, then 400 milligrams through 10 weeks, and then 200 milligrams thereafter through 6 months. And so the US guidelines are, if the Craig LFA titer is greater than 1 to 640, even if they don't have meningitis, assume that they do and treat for meningitis. And so where does that data come from? And so I'll skip through that. So if you look at the overall survival, this is a mixture of people with and without sort of low-grade symptoms, but in an outpatient setting, the higher the blood plasma titer, the worse the mortality is. So not a surprise. But if you just subset down on the people without symptoms, really this kind of, there's a big dichotomy here, as you can appreciate, where the people with greater than 640, they have worse mortality if they're treated with fluconazole alone, versus the people above seem to do okay with fluconazole alone. And so if you LP all these people, even if they're asymptomatic, so these are asymptomatic people, you can see the proportion of people who will be asymptomatic and be cryptococcal antigen positive and CSF increases dramatically. So at low titers, it's less than 10%. Most of those people, even if they are antigen positive or culture negative, they don't have high pressure. And so with fluconazole alone, they'll do okay. In the sort of 660 to 640 range, you can see, most people are still negative, but there's a proportion who are. And as you get higher, basically the majority of people will be Craig positive in CSF, even without symptoms. And so basically, if they've got a high titer, really more than 640 or really more than 160, kind of think about treating them for meningitis. And so do you need to do an LP on everyone? And so that's a great question. And so this was published just recently last month in the Acacia trial that's ongoing in Uganda, led by a colleague of mine, Radharaja Singham and David Maya, among asymptomatic people who are cryptococcal antigen positive in blood with low titers. And so they did titers and they were less than or equal to 1 and 80. There was no benefit for treating for meningitis over just giving fluconazole alone. You can see the Kaplan-Meier curves there. There's not any statistical difference there. And so if you did LPs on all these people and you gave them this was single dose liposomal ampho in addition to fluconazole, that didn't improve their outcome. And so we would say that in asymptomatic people with low titers, you can safely give them fluconazole, and you don't need to do LPs. You don't need to give them treatment for meningitis. That's not true if you have symptoms of meningitis, then you need to do LPs. Of course, you can't just say, oh, I've got a low titer, I can ignore it, because they could have something else in the CNS. So beyond just crypto. So people with high titers, it's unclear. These people do have higher mortality, and so it's a little bit unclear what to do with these people. And so there's 2 trials ongoing. One is giving adjunctive single dose liposomal ampho. Another is giving fluconazole in 5-FC in South Africa. So in summary, there's kind of diagnosis, there's treatment, there's pressure control, and there's prevention. And so to kind of summarize these, most people probably are using the cryptococcal antigen lateral flow assay. If you're not, then I would recommend it. It's just easier for the lab personnel to use, and it's a better assay. For meningitis therapy, there's sort of multiple aspects of this. The amphotericin flucytosine remains the gold standard backbone, and you can do single dose liposomal ampho plus 5-FC. That's my preferred regimen. So these are non-inferior, so there's no difference if you got one standard or another. I like the single dose regimen because it's less toxic, it's less expensive, and it's just overall easier to administer. And therapeutic LPs are very, very important. And so once again, if they did not measure pressure on your initial diagnostic LP, I would repeat the LP within sort of a day or two at most, because pressure control is highly critical, particularly in the first week. And then Craig screening and preemptive therapy. And so this is really strongly recommended less than 100 and considered less than 200. And so that would be things that I would strongly consider. So I think that is the end, almost on time, and be happy to take questions from people.
Great, thank you for a wonderful discussion about treatment cryptococcal meningitis. And I think you covered a very large landscape there, David. So thank you very much. We have a number of questions in the Q&A, and I'll just kind of start from the top. There are also a couple of questions that came in before the conference, so I'll get to those in a moment. So first question should be a simple one. Do you treat cryptococcal meningitis in the hospital?
Yes. So even if you're doing single dose liposomal ampho, they need to be hospitalized. Their pressure needs to be monitored, because even people that start with normal pressure, their pressure can go up. And so we generally, even though it's like, oh, they've gotten an IV infusion, like, can you send them home on day 2? I would say no. And so we generally don't discharge people for at least 7 days, because people's pressure can go up, and that can be a fatal event if it's uncontrolled.
Okay, this kind of follows on that question as well. To clarify, do you use, I think you said this already, you use single dose AmBisome in your US practice?
Yeah, so I use it. I mean, I guess I would be an early adopter in the crypto world. But yeah, and I think this is really about pharmacokinetics of the drug. And so there's been another study on histoplasmosis that looked at single dose AmBisome And so that was also sort of had similar outcomes as the daily 14 days dosing. And so there's other studies in the future that's going to be looking at Tallarmyces with single dose. And so I think it's a thing that could be looked at for a lot of different fungal infections.
And do you recommend therapeutic LPs regardless of the opening pressure, or?
Absolutely. So we would say do one on day 3, regardless of their baseline pressure, because you'll be surprised some people's pressure will increase over time. And as I showed, there's a mortality benefit for people who get at least a follow-up LP in that first week.
And how often should we be checking cryptococcal antigen after treatment?
It's generally not useful. And so this goes back to Judy Aberg's study that was published back in 2000, where antigens bounce up and down, and it's really not helpful either in CSF or in blood.
And boy, we got a lot of questions for you here. So how long do you recommend keeping a patient on fluconazole maintenance treatment after hospital discharge?
Yeah, so the recommendation is for people with meningitis to run it through at least 1 year. So if they're on ART, they're virally suppressed. Some people say, oh, the CD4 has to be above 200. It probably really doesn't matter, but if they're on ART, they're virally suppressed, and they've been on it for a year, you can generally safely discontinue it. Sometimes you will see late relapses or late paradoxical iris events that can happen years out. But that's relatively rare, but it's not impossible. But yeah, generally a year for people with meningitis and 6 months for people without, with just the Craig antigenemia without meningitis.
And if you use your single dose ambisome regimen, how long do you give the flucytosine?
For 2 weeks. So fluconazole and with the flucytosine for 2 weeks.
Fluconazole plus flucytosine.
Yeah, correct.
And there's a question, although we don't generally use this in the US, about treatment duration for the combination of amphotericin plus fluconazole if you're not using flucytosine.
Yeah, so the fluconazole, when you looked at the ACTA trial, the results were actually fairly good through 10 weeks of using fluconazole plus flucytosine. So if you've got, I don't know, there could be a situation, I mean, rarely in the US would you see this situation, but in low and middle income countries, that's a relatively good regimen. After 10 weeks, there was higher mortality than a amphotericin-based regimen, so it's certainly not my preferred regimen, but it's a pretty good regimen, and so it's certainly much better than just fluconazole alone.
And how about amphotericin plus fluconazole?
Yeah, so amphotericin plus fluconazole, once again, also in the ACTA trial, they did have, it was what, 45% versus 30% mortality, so it was almost 50% higher relative mortality with an amphotericin fluconazole regimen. And so flucytosine is a really critically important drug. It's just a cytosine, base pair with a fluoride group stuck on it, but it's a really important aspect of cryptotherapy at present.
And how about treatment of iris and cryptococcal meningitis?
Yeah, so if people with coming back in with second episode, the first thing is to try to exclude, do they have culture positive relapse? And so this is kind of tricky because if they got culture positive relapse, they need reinduction with amphotericin. If they have iris, you give them steroids. And so if you're giving people steroids with a positive culture, that's a recipe for disaster. And so oftentimes we can use PCR to differentiate that. Most places don't have that, and so sometimes you just do both, where you restart induction with amphotericin, you have a culture pending, and sort of high grade, relapses will grow within 3 to 4 days, and so you're using both steroids and amphotericin for the first couple of days until you kind of sort out which way it's going based on your culture result. And so that's the problem. And it also, obviously, if you can get a reliable history from a patient, that's great. Are they actually taking their medicines or not? Oftentimes, people with relapse are non-compliant with their fluconazole or their HIV therapy, and so they've got virologic failure plus they've got culture positivity. But not always. But that's certainly the most common scenario is people stopping their fluconazole and or their HIV therapy.
And I think you touched on this point, but maybe clarify it a little bit. In primary care treatment for people with HIV, the recommendation is to screen with a cryptococcal antigen. If the CD4 count is less than 100, then you start fluconazole. And then at what point do you stop the fluconazole? Do you repeat a cryptococcal antigen, or do you wait till the CD4 count reaches a certain threshold? And then for how long past that threshold do you continue the fluconazole?
Yeah, so generally it's kind of a step. So yeah, if you screen people less than 200 or less than 100, it sort of depends on your health system or country's guidelines. But yeah, if they're cryptococcal antigen positive, sort of higher dose fluconazole at 800 milligrams for 2 weeks, and then 400 milligrams for another 8 weeks, so through week 10, and then 200 milligrams, so 1 tablet once a day through 6 months. And that's fairly adequate therapy. You get them on HIV therapy, generally starting 2 weeks after their initial fluconazole, and they should be virally suppressed within a month or two, and they should be doing quite well. I should say month or two, but yeah, they'll be virally suppressed long before 6 months, ideally, and you can stop safely at 6 months.
Okay. Let's see. I think you've answered. There's one
You just
question.
got a good question there about Cryptococcus gattii in the Northwest. And
Yeah.
so that's a great question. I think, yeah, that the function of the drug, as I showed the graphs where you have the EFA, this early fungicidal activity, the rate of fungal clearance, the antifungal activity is the same with a single dose regimen as with the daily deoxycholate or regimen. And so there's no difference in the antifungal activity. So I think you can extrapolate the antifungal aspect of that therapy. The question is based on your patient. Do you need immunomodulatory therapy, steroids, other things? Maybe a little bit more complicated based on who your patient is. But for antifungal therapy, I think you can extrapolate across from neoformans to gattii.
Okay. And so there's a question here about recurrent cryptococcal meningitis. We don't see that a lot in the US, but you probably do see it a lot more in low and middle income countries. What's your approach to that?
I think the same thing of, is it paradoxical iris versus a culture positive relapse on their second episode. And so deciphering, are they taking their medicines, making sure they're on their HIV therapy and they're virally suppressed. And then you can also look at the fluconazole MIC. And so particularly the first episode, getting susceptibilities is not super important, but we do see a fair amount of fluconazole resistant yeast on the relapse isolates. And so sometimes that may change what you're going to do. You may have to increase the dose. It may get a little bit more complicated if you've got a really high MIC to your isolate. And so even if you have you've got a cryptococcus with a MIC of 32 or 64, which is sort of relatively high grade resistant, what we generally do is once again try to suppress people, get their CSF sterile with amphotericin-based therapy. And so this would be a role where you probably would do daily dosing to make sure that you're suppressed, and then you just give a higher dose of fluconazole maintenance therapy.
And I'm not sure I fully understand this question. You might better than I. Something about the cryptococcal antigen LFA demonstrating prisoner phenomenon. What is that?
So you can have a sort of a high dose hook effect or a prozone, sort of a anti-prozone effect. And
okay.
so
Prozone effect, that's what I wondered. All right.
Yeah, and so it's kind of a prozone phenomenon where you've got so much antigen, it sort of overwhelms that. We've seen that once in the last 14 years, and so it's pretty rare. And so that patient had, I think it was like 5 million yeast per milliliter of CSF, and so it was sort of overwhelming. And so if you did anything looking at the microscope, it would have been incredibly obvious. One of the companies, EMI, is making a semi-quantitative lateral flow assay, which is really like a grade 1, 2, 3, 4, 5. And so that will actually be prozone proof. And so it'll actually eliminate that. And so that's something they've developed, and they're undergoing field trials for FDA registration. But
Great.
it's a theoretical concern that it's really rare, and it's it's, yeah, not really that big of an issue.
All right. Okay, we're out of time for the Q&A, and we may be able to get back to the last remaining couple later on in the conversation today, but now it's time for our morning break, which many of you may be looking forward to. But thank Dr. Boulware for a real tour de force on cryptococcal meningitis. And we appreciate all of your attention and great questions. We will take a break now and restart our program exactly on time at 10:25 Pacific time, which means 25 minutes after the hour, wherever you are watching from. And we'll come back with Dr. Bedimo hosting at that point, and I will be doing a lecture. So time for a break, everyone. Thank you.